I'm Dr. Chetan Hande. I'm WHO consultant for National TB Elimination Program for Kolhapur Division. So today's topic mainly is going to be a little programmatic overview, what is there in the TB program and what are the recent updates. We'll just, looking at the time constraint, we'll try to complete, have in just overview of the program. So first, before starting, first we need to know what is the burden, why this TB program, why the priority has been given to the TB program. As you can see, burden, which we generally quantify in terms of all the three basic indicators, that is the incidence of TB, your mortality of TB and MDR incidence. So according to this global TB report, you can see what is the global burden of TB, and incidence is 10.6 million. And what is the contribution of India? We are contributing approximately 2.8 million, like 27%. Similarly, with respect to mortality also, globally 1.13 million, and out of that, the mortality which is seen in India is 3.31 lakhs. Again, it is 27%. And third indicator or third variable is MDR cases. As you can see on this slide, MDR also, our contribution to global MDR cases is 27%. So as you can see, the burden of India, the burden which India contributes towards TB in terms of incidence, your mortality in TB and your MDR case is 27% of all the global cases. So that is why this priority in the program to identify more and more cases and to specifically address this burden. So what are we doing? From 2018 onwards, the Government of India is committed to ending TB with respect to the global Sustainable Development Goals targets. So these targets are based on indicators like incidence, mortality and out-of-pocket expenditure. So what is the target? The target for incidence is 90% reduction in incidence, and this reduction is according to the 2015 baseline. Like what was the incidence since 2015? Our target for global SDG target is reducing the incidence by 90% with respect to 2015. Again, mortality, decreasing the mortality by 90% with respect to 2015, and out-of-pocket expenditure means the economical burden which a TB patient and his family suffers because of this TB. So we have to reduce it to zero or come down to zero. So these are the three targets, the Sustainable Development SDG goals which have been enumerated globally. So what we are doing in program, we are trying to achieve or at least make efforts to achieve these goals by 2025. So again, the indicators are same: incidence, mortality and out-of-pocket expenditure. So right now, what is the status? So as you can see, in 2015 baseline, this is 217 per lakh population was the incidence in 2015. We have to reach to 44 per lakh. Again, the 34 is the mortality of TB. In 2015, it is 34 per lakh. We have to reach to 3 per lakh. Okay, mortality. Right now, at our current rate of annual incidence or decline in incidence and decline in mortality is only 3%. Expected is 15%. Right now, you can see current level according to this Global TB Report 2023, which is based upon the data of 22. According to that, you can see incidence is 196 per lakh population, and current mortality per lakh population is 23. So still, there is a long way to go ahead. So to address this and to facilitate or to accelerate the decline, there are certain intervention or certain implementation strategies which has been incorporated in this National TB Elimination Program. So we're going to just have a look on what are the strategies. So this is the National Strategic Plan from 2017 to 25. So there are, in short, there are 4 components. First is detect. That is finding all the TB cases with emphasis on reaching every TB patient in private sector. Second is treating all the TB patients with high quality anti-TB drugs. Prevention is preventing the emergence of TB in susceptible population and stopping the catastrophic expenditure. And fourth is the building and strengthening the whatever the support systems we have to strengthen that and enable the policies and empowering institutions and human resources to address this this TB disease. So I'll be going in short in each of the components. So in detect, there are, as you can see, WHO approved diagnostic options under NTP. Right from microscopy, we have recently, in last couple of years, we are transitioning towards NAT, that is nucleic acid amplification tests. Okay, So right now for Kolhapur Corporation, we have around 11 NAT machines, true NAT machines at urban PHCs, and there is a CB-NAT machine at D.Y. Patil Medical College. So we are transitioning from this microscopy to providing NAT, that is upfront NAT to all the presumptive TB cases. Okay. Regarding CB-NAT and TrueNAT, I'll not go into much detail. There have been speculations regarding the sensitivity, but there are studies which support that sensitivity of TrueNAT and CB-NAT is comparable, and looking into aspect like cost effectiveness and expansion up to the grassroots level. So we are relying more on the indigenously developed TrueNAT machines, so that this can be brought up to the grassroots level, taking into consideration the portability and the manpower and the skill which is required to operate the machine. Okay. Next is what type of specimens are required to be run on these machines. So biological, for pulmonary, you know, there is a sputum sample, two samples, spot and morning is required. Okay, the quality should be mucoid, deeply expectorated, minimum is 5 ml. For extra, and these has to be for TrueNAT and CB-NAT, it has to be transported in Falcon tubes. So these are being provided at every UPHCs, and I think so the TB team, the CTO team, city TB officer team, they are approaching the private practitioners also. So we are keeping this Falcon tubes, and whatever the services are required for the sample collection and transportation and getting it tested at the NAT sites, that help is provided by the city TB office. Now, what other than pulmonary samples, what other samples can be run on CB-NAT and TrueNAT? Gastric lavage, BAL, CSF, pericardial fluid, synovial fluid. So all basically in extrapulmonary also, whatever the samples are available, okay, what can be aspirated or can be, that also can be run on these TrueNAT and CB-NAT machines. Okay. For extrapulmonary, important is additionally, apart from this, the samples which we discussed, which can be run on NAT, other investigations which are helpful in diagnosing extrapulmonary cases, like these can be radiological, cytological. So not just depending upon the microbiological testing, other modalities can also be utilized to identify the TB and to start the patient on the appropriate regimen. Okay. Now coming to treat part. So under treat, we know there are specific guidelines which are provided by Ministry of Health and Family Welfare and Central TB Division. So there are regimens for DSTB and there are regimens which are provided for DRTB. For DSTB, as we know, it is a 6-month duration, 2 months intensive phase and rest 4 months of continuation phase. So in IP, we are providing 4 first-line drugs in a fixed dose combination, which are according to the weight bands for adult and for pediatrics. Okay. So as you can see, these are the FDCs according to the weight band for DSTB regimen for both intensive phase and continuation phase. So in intensive phase, we can see there are the fixed dose combination comprises of 4 drugs, isoniazid, rifampicin, pyrazinamide, ethambutol, and continuation phase is HRE. Okay. So these FDCs also has to be given according to the weight of the patient. Next is for pediatric also, it is similar. FDCs are available, but instead of 4 FDC, we have 3 FDC and an ethambutol tablet in intensive phase, and continuation phase we have HR and FDC of HR, and then we have ethambutol tablet. Again, these are all weight based. So certain newer drugs, this is a recent update, certain newer drugs like bedaquiline, delamanid, these are also available under the program. But right now it is only, it is not available in private sector. It is just being restricted to the public sector, and patients who are diagnosed as MDR, for them the regimen which is available from the nodal or district DRTB center. But these drugs are available at the nodal and district DRTB centers. So any patient, depending upon the drug sensitivity status, the rifampicin status, the isoniazid status, there is an algorithm by which we can see whether the patient comes under and what kind of DRTB regimen. So these are the few DRTB regimens. First is for H-mono. As we know, if there is a resistance to isoniazid, we can start on H-mono regimen. I'm not going to go into detail of all the drugs. So this is just for an overview, like what is the regimen for H-mono. Similarly, 6 or 9 months of DRTB regimen. Again, for MDR or RRTB or XDR-TB, there are two types of regimens which are available. One is the shorter oral bedaquiline containing MDR or RRTB regimen. Other is all oral longer MDR or XDR-TB regimen. So in both these regimens, bedaquiline is being introduced. Okay, and to start this treatment, we need to see with what kind of resistance pattern is there. Okay, see if rifampicin resistance is there or not, or isoniazid resistance is there or not, depending upon the first line LPA reports. Okay, what we know right now, what up to the district level, what modalities are offered is your NAT. But after NAT, the next step to identify the resistance pattern to remaining first line and second line drugs, there is a rapid molecular diagnostic test called LPA, line probe assay, which is being offered at the Intermediate Reference Laboratory, Pune. The sample of those patients, after getting diagnosed at NAT, they are sent to the IRL, and the status of the resistance pattern for first line and second line drug is identified, and depending upon what the resistance pattern is, we can start the patient on this particular MDR regimen. Next is the prevent aspect. So majority of the updates under the program is under this prevent component. So again, rationale for this prevent, why we need to focus more on prevention. See, we are upscaling, or we are accelerating the identification of presumptive cases, the diagnosis of TB cases. We are having quality drugs for treatment of DSTB and DRTB. But where we have to focus our attention is for prevention of TB disease. So globally, it has been estimated that in India, approximately there is 30 to 40 crore population which are infected with TB. So there is a difference between TB infection and TB disease. So what we need to focus is to identify this population or this pool of individuals or population infected with TB, and to prevent the transmission from TB disease to TB infection to TB disease. Because a TB infected individual, there is a lifetime risk of 5 to 10% of that individual to develop TB disease. Again, once there is infection with TB, there are certain risk factors depending upon which there is a transition from TB infection to disease. These are basically the immunological status. Again, second is the contact of pulmonary TB patient. Okay? There is an increased risk of transition from TB infection to disease in these populations. Again, other high-risk groups like PLHIV and other immunocompromised status like diabetes. In these population also, there is a risk of developing disease. Like in PLHIV, 16 to 20 times more than the general population. And in immunocompromised status like diabetes and other non-communicable disease, there is a risk of 3 to 4 times of this disease infection getting progressed into a disease. So again, there has been questions regarding this TPT. Yes, this has been recommended by global WHO guidelines. Like it recommends giving TPT. There is efficacy. There is a reduction of 60 to 90%. Those who get TPT, those who are provided TPT, comparison to those who are not. So these are, I have just mentioned the reference studies for regarding this efficacy, safety, and the risk of drug resistance. Also, there are questions regarding this drug resistance for both, like isoniazid as well as the newer regimens which are coming up, like 3HP. So there are evidences, like as you can see, we have mentioned the reference studies, which says that the resistance, which we assume it might be more if we give monotherapy, or if we are giving these monotherapy drugs or the TB drugs to individuals who are not diagnosed as TB. But the development of resistance, which has been seen under this study, is very less. Like there is absolutely no evidence, or even if there is an evidence of resistance, that is in 0.02 or 0.03%. Okay, I've just mentioned the studies which are supporting this the statements. Again, the protection for TPT lasts with 6 to 19 years. There are various studies right from 2015 to 19 saying that the protective period, obviously there is protective period after giving TPT. Okay, so these are the studies. Right now, in the state of what there are national level guidelines for providing TPT. So there are we are giving TPT basically to contacts, household contacts of a pulmonary TB case, pulmonary, whether it is bacteriologically confirmed or it is a clinically diagnosed case. So we are providing, we are offering TPT to those contacts of index pulmonary TB patient. So for this, giving TPT also, there are two policies which has been laid down. First is test and treat policy, and then other there is treat only policy. So for the state of Maharashtra, what we had developed is, what the state has developed is we are going to go with, up till now there was treat only policy, and in districts where there is availability for TB infection testing, so that can be offered. So it is not universal, it is not same for all the districts. Districts where the IGRA facility is available, they are going with test and treat policy. For the district of Kolhapur, we are going for this. Right till now, we are undergoing this following this treat only policy. So what is the treat only policy? First is, obviously, see, there are target groups also for whom TPT is to be given. PLHIV cases, obviously those PLHIV patients, because there is a higher chance of PLHIV patients developing TB, so they are being given TPT. So that part is giving TPT in PLHIV patients is taken up by the ART centers and NACO. For household contacts of pulmonary TB patient, first and most important thing is ruling out of active TB disease. So all the household contacts of pulmonary index TB patients, they are seen, they are screened symptomatically whether there is any symptoms of TB. If there are any of the TB symptoms in contacts, they are investigated for active TB disease. And if there is, obviously there is some TB detected, MTB detected, so obviously they will be given provided the DSTB or DRTB regimen depending upon their resistance pattern. And if there is no active TB, then that individual can be given TPT, taking into consideration whether there is any contraindication or not. Similarly, if there are no symptoms in the household contacts, so depending upon whether the age is more than 5 years or less than 5 years, they can be obviously given, if there is availability of TB infection testing, like IGRA is there, or the new CY-TB test which we are going to introduce in the coming months. If the test is available, the individual can be offered the test. If the test is positive, okay, and there is no other abnormalities, whether on X-ray or any symptoms of TB, and TB infection test is negative, then we don't need to give any TPT. If the test is positive, we can give the TPT. So up till now, what we were doing is, after in certain contacts, if there is no symptoms of TB, X-ray is negative, no symptoms of TB, then also we were providing him with the TPT. Okay. Now in coming months, there might be a change in policy after the introduction of the newer CY-TB test for TB infection. Like we had skin test, like we had some TST was there, Montu test was there. Then IGRA, you might be knowing this spot TB test or quantiferon gold test is available, but because it is it is not that cost effective, it was not included in the program. In coming months, the CY-TB test is going to be available. So if that test is available, we can provide that test to the contact, and if the test is positive, then we can start with the TPT. If the test is negative, then it's okay to stop and observe. But we have to observe whether the contact develops any symptoms of TB during the course of treatment of this pulmonary index patient. Okay. So these are the tests which were recommended. Right now, as we know, TST, the specificity is not that much. The presence of previous BCG vaccination, it obviously interferes with the disease. With the test, there are false positive results. Okay, the better test than that was IGRA, but because it is under the programmatic circumstances, it is not possible to provide IGRA to all the household contacts. So right now, CY-TB test, which has been developed by Serum Institute of India in collaboration with my lab, they have combined this, the principle behind this IGRA tests and the administrative procedure of this skin TST. Like CY-TB is also now given intradermally on the forehand, okay, but the solution which is being introduced, that the antigens in that CY-TB solution, it is similar to those which are being provided in this IGRA test. So it is basically a combined combination of TST and IGRA. It is more robust, it is cost effective, it is field friendly, and it does the previous BCG vaccination does not interfere with the test. So the specific the antigens which are present in this CUI-TB is based on ESAT6 and CFP10 antigens of MTB. These are the same antigens which are being utilized for this for the IGRA test. But IGRA test it is done ex vivo, like serum sample, the blood sample is taken and it is subjected to these antigens. And if there are interferon gamma responses there, then the IGRA test is positive. Similarly, here also these antigens are given in the right, like the MON2 test. And if there is any induration and the induration is 5 mm or more, then we declare the test as positive. Okay. So this is the new component which is we have actually received the vials up to the division level. So in coming months, like in November or December, the CY-TB test will be offered to all the contacts of pulmonary TB patients. So other part is what is the regimens for this TPT. As we know previously, up till now, in last 2-3 years, before that, TPT was given, or isoniazid, as you know, it was given to contacts less than 5 years of age. But from 2022, newer guidelines have been introduced. It has been said that the guideline says that we can give TPT for all the household contacts which are less than 5 also and more than 5. So right now we are offering TPT to all the household contacts irrespective of the age. Here in this slide, I would just like you to focus on the household contacts below 5 years and household contacts 5 years and above. For them, first step obviously is ruling out TB. If there is no signs and symptoms of TB, or test is also TBI test is negative, then we can offer them TPT. So the regimens which are available in the program is 6H and 3HP. So the 3HP 6H drug, as we know, it is a daily dose regimen. It is giving for 6 months, and we are giving 6 months of isoniazid. 3HP is the newer drug which was introduced 2 or 3 months back. That it is a FDC which contains, it's a combination of isoniazid as well as rifampicin, and it is given for 3 months. This 3HP, it is a weekly dose, like once a week dose. It is given for 12 weeks, like 3 months. What INH was given? INH was given daily dose for 6 months. But this 3HP, we are giving weekly dose for 3 months. Okay. There is one more regimen which is 1HP. Now, right now, this 1HP is restricted to PLHIV patients who are more than 13 years of age. 1HP, 1 indicates 1 month of treatment. Again, it is a combination of isoniazid as well as rifampicin. So here you can see the advantage of 3HP is it is doses, 12 doses, that is weekly once dose given for 12 weeks, and the pill burden is only 3 if we are giving in fixed dose combination form. So that each drug, each FDC or each tablet, it is 300 mg of isoniazid and 300 mg of rifampicin. So like this we have to give 3 tablets once a week, and that has been given for 12 weeks. I will not go into the regimens. At the end, I would just like to tell about the adult BCG vaccination. Right now, under this prevent strategy, in Maharashtra, there are approximately 40 districts where this adult BCG vaccination is being carried out. Household surveys has been undertaken. So inclusion criteria was those 6 high-risk groups. Okay? These are the previous history of TB, close contacts of TB patients, individual more than 60 years, individuals with history of diabetes, history of smoking, and BMI less than 18. So these were the high-risk groups which were included under this survey who are being offered adult BCG vaccination. Just to show about the rationale, so there was Chigliput trial already which has taken place in the 1970s. So again a reanalysis was done, and what was found out at the CTD level was there is a modest protection with approximately with 36% against the development of TB disease at the end of 15 years. So that trial was conducted for 15 years, and at the end of trial we can see that there is protective efficacy. Another study is also there which says that there is immunological boosting after BCG revaccination. So there are rationales for this. There are also countries where this adult BCG vaccination or BCG booster doses is been given. There are 16 other countries, and the age in where this adult BCG vaccination or booster dose is given, that is between the age of 7 years to 13 years and above. Okay. So this is one more addition under this TB program. Okay. So right now, what is the see? This is the program where private sector engagement is given much more focus. Okay. So just last point. We would just request that the involvement from the private sector. There are certain facilities which are available under NTP. We would like you to utilize them. That is provided. The treatment regimens are there. We would like you to send as much as samples for TB testing, and hopefully with the help of the private sector we can take steps forward to ending this or achieving this goal of NTB. I would like to call Dr. Amar Pawar. He is city TB officer. He'll just brief you about one more implementation.
Dr. Hande, you be there on the stage only,
yes,
so that we can keep the question answer session after that. Dr. Amar Pawar.
म्हणजे कोल्हापूर शहर कार्यालय शहरामध्ये कशा प्रकारे NTP प्रोग्राम राबवतो, म्हणजे नॅशनल TB इलिमिनेशन प्रोग्राम, याच्यामध्ये एक 5 मिनिटात माहिती देतो तुम्हाला. त्याच्यामध्ये आपण मायक्रोस्कोपी आहे ते आपण टोटल फ्री करतो. त्याचबरोबर ट्रूनेट, सिग्नेटसारखे मशीन हे सर्व प्रायव्हेट डॉक्टर्सना माहिती आहेत. आपण त्याची सर्व्हिस फ्री, तसेच जितकी जलद होईल तितके मी प्रयत्न करतो तुम्हाला रिपोर्ट ज्या त्या दिवशी मिळेल याचा. त्याच प्रकारे फर्स्ट लाईन, सेकंड लाईन LPA टेस्ट असो, ह्या देखील आपण फ्रीमध्येच करतो. त्यानंतर आपण आता जे शहरातले काही अगदी गरीब रुग्ण आहेत की ज्यांच्याकडे अगदी म्हणजे सोनोग्राफीला किंवा बायोप्सी असेल, FNAC असेल किंवा MRI HRCTला पैसे नसतील, अशा गरीब रुग्णांना देखील आपण जर तो पेशंट त्याला 4A सिम्पटम असेल, TB संदर्भात लक्षण असेल, तर त्याची आपण त्या तपासणी पूर्ण मोफत करतो की ज्याद्वारे त्याचं डायग्नोसिस, निदान आपल्याला जलद होण्यासाठी. निदान झाल्यानंतर त्याला मेडिसिन, जर मेडिसिनसाठी आपण सर्व मोफत उपचार करतोच, पण काही MDR पेशंटला ज्यांना बेडाक्युलिनसारखी मेडिसिन लागतात त्यांचा खर्च अगदी लाखांच्या घरात आहे, तर तोही पूर्ण गव्हर्नमेंट तसेच स्टेट गव्हर्नमेंट व आपल्या कोल्हापूर महापालिकेअंतर्गत आपण पूर्ण मोफत देतो सर्वांना. पण इतकंसं करून देखील काही रुग्ण हे म्हणजे त्यांचं डेथ होण्याचं प्रमाण पण आहे समाजामध्ये भरपूर. ते कमी करण्यासाठी सेंट्रल TB डिव्हिजनने 22 जुलै 2022 रोजी एक प्रधानमंत्री TB मुक्त भारत या अभियान म्हणून एक योजना आणली की ज्याच्यामध्ये निक्षमित्र म्हणून समाजातल्या जे दानशूर व्यक्ती आहेत त्यांना त्यामध्ये समावेश करून जे गरीब रुग्ण आहेत त्यांना फूड बास्केट स्वरूपात आपण मदतही करू शकतो. अशा स्वरूपात जर कोणाची इच्छा असेल तर तुम्ही आपल्या डॉक्टर दळवी मॅडम यांची संपर्क करू शकता जर कोणाला इच्छा असेल तर. मी जास्त वेळ घेत नाही, कारण जरी सर्व प्रायव्हेट डॉक्टर्सना आम्ही आमच्या CTC मार्फत सेवा देतो आहे, जर कुठे काही त्यात इम्प्रूव्हमेंट हवी असेल तर कृपया त्यांनी आम्हाला सांगावं. आम्ही त्यामध्ये निश्चितच सुधारणा करू आणि जितके सक्षम आणि आम्हाला होईल तितकी शक्यतो चांगले उपचार तसे तुम्हाला चांगली सेवा देण्याचा आम्ही प्रयत्न करतो. धन्यवाद.
धन्यवाद डॉक्टर अमर पवार. Question session is over. If any questions anybody has, chairpersons also can ask questions if required. We can take only 1 or 2 questions.
Yeah.
This
Thank you, Dr. Hande. It's a crispy bread.
Sir, that group is also included into this. So to start adult BCG vaccination, there are 6 criteria. So under that criteria, one is more than 60 years age group, which is a high risk group or a vulnerable group where chances of TB infection, TB disease are more. So that group is also included under the BCG vaccinations.
And I think the BCG vaccination, the trials, Kolhapur district is already there in the trial, and almost 36% reduction in the incidence of getting TB in the adult population. That's why I think slowly the BCG vaccine is going to come into the clinical picture as we are doing for anybody above age of 60 with the influenza and the pneumococcal vaccination. That's going to be a part of. Thank you very much.
Thank you, Dr. Hande. I request chairpersons to give memento and certificate to Dr. Chetan Hande, and we will proceed with our second session. Thank you.